This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, a senior attending here, and I'm joined as always by our research fellow.
And I'm Dr. Alara. Today we're looking at a fascinating new study from the journal Medicine, published in 2026, titled Development and Validation of a Prediction Model for Postoperative Cerebral Edema Progression in Emergency Traumatic Brain Injury Patients.
This is a topic that hits home for anyone who spends time in the neuro ICU. We all know that traumatic brain injury, TBI, is a leading global cause of death and disability. When these patients come into the emergency department with severe injuries, we often rush them into an emergency craniotomy or a decompressive craniectomy to relieve herniation or evacuate a hematoma.
Exactly, Dr. Aris. But the paper points out a sobering reality. The surgery itself can act as a secondary insult. It can actually induce or exacerbate perioperative cerebral edema. When that edema progresses postoperatively, it's a major complication that leads to clinical deterioration and poor outcomes.
And that's the clinical black box we often deal with. Progressive postoperative cerebral edema causes a recurrent increase in intracranial pressure, or ICP. It can trigger secondary herniation and severely impair neurological recovery. The authors of this study, Zhang and colleagues, mentioned that we often only detect this progression when clinical symptoms become obvious or when we see clear radiological signs on a follow-up CT.
Right, and by then, the therapeutic window for intervention might have already closed. This study aimed to identify high-risk patients early, before those clear signs emerge, to allow for targeted therapies like optimized sedation, precise hyperosmolar therapy, or even prophylactic hypothermia.
So, Alara, let's look at how they built this model. It was a single-center retrospective observational cohort study, correct?
That's right. It was conducted at Qingtai People's Hospital. They enrolled 201 consecutive TBI patients who underwent emergency craniotomy between January 2023 and December 2024. To make the study robust, they used a time-split method. They took the first 70% of patients, that's 141 people, and put them in the model development cohort. The remaining 30%, 60 patients, were used as an internal validation cohort.
I like that they used the time split method. It's a bit more rigorous than a simple random split for validation. Now, how did they actually define cerebral edema progression?
They used imaging and clinical criteria within the first 72 hours postoperatively. In their total sample, 63 patients fell into the progression group and 138 were in the non-progression group.
That's a significant percentage. Nearly 31% of the patients had progression. For the residents listening, let's get into the meat of the paper, the predictors. They started with univariate logistic regression and then moved to multivariate analysis to find the independent predictors. What were the lucky 7 that made the final model?
The model identified 7 independent predictors. Some are what we would expect, but having the specific odds ratios is very helpful.
Let's break them down one by one. First, demographic and admission status.
First is increased age. The adjusted odds ratio, or AOR, was 1.02 per year. So for every year older the patient is, the risk of edema progression increases slightly. Second is a lower admission Glasgow Coma Scale, or GCS score. The AOR there was 0.86 per point. This means for every point the GCS drops, the risk of progression goes up.
That makes sense. Older brains and more severe initial neurological deficits are naturally more vulnerable. Now, what about the imaging markers?
These were very strong predictors. Third on the list was a larger volume of cerebral contusion or hematoma, with an AOR of 1.06 per 10 milliliters. Fourth was the degree of midline shift, with an AOR of 1.12 per millimeter.
So for every millimeter of shift we see on that initial CT, the risk of postoperative edema progression increases by 12%. That's a very practical metric for a resident to keep in mind when they're looking at the scans in the ER. But the study didn't just look at admission data. It looked at the first 24 hours post-op, right?
Exactly. They included physiological and laboratory responses. The fifth predictor was the maximum intracranial pressure within the first 24 hours postoperatively. The AOR was 0.11 per millimeter of mercury.
This is crucial. It shows that even after we've surgically decompressed the brain, the behavior of the ICP in those first 24 hours is a window into whether the edema is going to worsen over the next few days. What were the last 2?
These involved the systemic response. The sixth predictor was a lower serum sodium level within 24 hours postoperatively, with an AOR of 0.91 per millimeter per liter. And finally, the seventh was an elevated C-reactive protein, or CRP level, with an AOR of 0.03 per 10 milligrams per liter.
Interesting. So hyponatremia and systemic inflammation, represented by CRP, are key players here. We often talk about the fragmented way we assess these patients, looking at the CT, then the labs, then the GCS. This model integrates all of that.
It really does, and the performance metrics were impressive. In the development cohort, the area under the receiver operating characteristic, or AUC, was 0.901. In the internal validation cohort, it held up well with an AUC of 0.875.
For our medical students listening, an AUC of 0.9 is generally considered excellent discrimination. It means the model is very good at distinguishing between a patient who will have edema progression and one who won't. Did they look at calibration?
They did. They used the Hosmer-Lemeshow test and calibration plots. Both showed that the predicted risk closely matched the actual observed risk. They also performed a decision curve analysis, which confirmed the model has clinical utility, meaning that using this model to make decisions provides more benefit than just assuming everyone is at risk or no one is at risk.
Let's dive deeper into why these specific factors matter. The paper discusses that advanced age might be linked to poorer vascular integrity or a reduced capacity for the brain to handle the inflammatory cascade. And the GCS, of course, reflects the initial load of the primary injury.
And the volume of the contusion and midline shift are classic markers of the physical energy transfer to the brain. But I find the CRP and sodium levels particularly interesting. The authors suggest that elevated CRP reflects the intensity of the systemic inflammatory response, which we know can break down the blood-brain barrier.
Absolutely. And the lower serum sodium is a classic concern. Whether it's from SiADH or just fluid shifts, hyponatremia creates an osmotic gradient that pulls water into the brain cells, exacerbating cytotoxic edema.
What I think is most valuable for us in the hospital is the inclusion of the maximum ICP from the first 24 hours. Often we think that if the post-op ICP is okay, we're out of the woods, but this study shows that the peak value in that first day is a significant herald for what's coming in the next 72 hours.
It's a call for vigilance. If you have an older patient who came in with a GCS of 6, a 15 millimeter midline shift, and then their ICP spikes to 22 millimeters of mercury on the first night, even if it comes back down, this model is screaming at you that they are high risk for edema progression.
Exactly. The study suggests that for these high-risk patients, we shouldn't wait for the follow-up CT at 72 hours. We should perhaps be more aggressive early on. Maybe that means keeping them more deeply sedated or being more proactive with hyperosmolar therapy to preempt the swelling.
Now, every study has its limitations. This was a single-center retrospective study. While 201 patients is a decent size for a specialized prediction model, it's still just one hospital's experience.
True, and they only followed the patients for 72 hours postoperatively. While that's the peak window for edema, it doesn't tell us about the long-term functional outcomes at 6 months or a year. However, the authors did conduct a subgroup analysis, which showed the model's stability across different patient types.
This paper represents a move toward precision neurosurgery. Instead of treating every TBI patient with a one-size-fits-all post-op protocol, we can start to quantify individual risk. It's an objective decision support tool.
It definitely beats the gut feeling method. When we can say a patient has a specific combination of risk factors, age, GCS, contusion volume, midline shift, post-op ICP, sodium, and CRP, we can justify the use of more intensive resources.
To wrap up, Ilara, what's the take-home message for our colleagues?
The take-home is that post-operative cerebral edema progression is predictable. By integrating these 7 clinical, imaging, and laboratory indicators, we can identify high-risk emergency TBI patients within the first 24 hours after surgery. This model, with its AUC of 0.875 in validation, provides a reliable framework for that early warning.
Well said. It's about catching the progression before the therapeutic window closes. If we can intervene early, we might just prevent that secondary herniation and give these patients a better chance of recovery.
Definitely. It's an exciting step forward in TBI management.
Thank you, Ilara, and thank you to our listeners. We'll link the full study by Zhang et al. In the show notes. Until next time, this is the Neurosurgery Hub podcast.
See you next time.